Let's move to our we have three cases presentation from Bahrain, and Professor Baz will present us a case from Germany for diabetes, and we hope you will enjoy this interactive session between you and between our eminent guest speaker. So we'll go for the first case. Mr. X is 50 years old male with diabetes mellitus on maximum dose of sulfonylurea. IHD, ischemic heart disease, dyslipidemia, osteoporosis, with complaint of recurrent chest tightness. On examination, body weight was 80, height 160 centimeter. The patient was lying flat in bed. Pulse was 100 beats per minute. Blood pressure 110 by 7. Chest shows few basal crackles. Heart, no abnormality. Abdomen, no abnormality as well. Investigations for this patient. Triglyceride was 500 milligram per deciliter. Total cholesterol 260 milligram per deciliter. LDL 130. HDL 30 milligram. Hemoglobin A1C looks nice, 6.8. RPS is 150 milligram per deciliter. Urea, creatinine, liver function test, all are normal. Alkaline phosphatase 320. Calcium, parathormone, LFT is normal. Vitamin D normal, 20. ECG shows anterolateral ischemia. Echocardiography shows ejection fraction 30%. PMD T-score minus 2.5. So I think it is clear now. Patient is ischemic heart disease having low ejection fraction, osteoporosis. T-score is minus 0.5. And is having dyslipidemia and diabetes. So we'll start first question. For management of dyslipidemia, would you like to start with fibrates, statin, or both? Can I take the opinion for our audience first before going to our guest speakers? Any comment for these cases? Can you put light, please light? Dr. Bonini, you'd like to comment? You want to start with fibrates? Any other who agree or disagree? No more comments. Okay, can we go and take opinion of Professor Zaki about dyslipidemia in such case?
And statins also have a very good effect, but fibrate is more effective on triglycerides. In these cases, we prefer to use both, because if you use statin, you reach a maximum point, and the triglycerides will not reduce below this. And it is safe to use fibrate with statin in this condition.
Professor Paz, you have a comment? Because this will give us how can the debate between cases and how to do. Professor Paz.
I wouldn't give him fibrates. I would give him only statins. And I would tell him to restrict from alcohol, have a diet with long-acting carbohydrates and physical activity, because we see in a lot of diabetic patients that they have high triglycerides, and when they change the dietary regimen, the triglycerides fall down. But he's a high-risk patient as to cardiovascular disease, and I would decrease his LDL level because it was 130, and it should be below 100 or even 75, and you can do it by statins. So only statins.
In such case, you take guideline for LDL or non-HDL, because triglycerides is 500.
It wouldn't matter. I would check it again, and I think when he's on a diet, he will have about 250 or 200. I wouldn't give him fibrates. Just statins.
But Professor Zaki, you will give both, and then you will follow up for the liver enzymes, right?
No, I prefer to start with statin. Statin will reduce both, and if and you will wonder that the LDL will be low, and the triglycerides are not that reduced. So
Dr. Wanim, yes?
Yes, this patient, I think it has familial hypertriglyceridemia. From my own point of view, this is not a problem of vessel. I'm caring about the pancreatitis. I'm afraid of pancreatitis mainly due to very high triglycerides. So my thinking that the first priority is to control the triglycerides first. For starting with the statin, I will benefit just 15% from statin as regards decrease of the triglycerides, which is very little. I need to decrease the triglycerides in this patient more than 80%. And I think that the statin is whatever you increase the dose will not give you that. So I prefer to start with fibrates. The second point is that we are not enthusiastic to give fibrates with the statin because we have seen cases with myositis and weakness of the muscle if we add fibrates to statin. This is the point that I depend upon.
Statin is usually beneficial in many cases. They have no effect on liver enzymes. This patient had elevated liver enzymes. And it was wrong to say that statins should not be given to a patient with elevated liver enzymes. Now they are giving it as a treatment to hepatitis C because it blocks the receptor for the virus itself. So when you got elevated liver enzymes, they call it now transaminitis. What is meant by? Because you see a lot of people with just mild elevation of liver enzymes, and you are worried about statins to be used in these conditions. And it was noticed that elevated liver enzymes should be at least 3 times or more to judge that you should stop statin. This is my impression. In this case, the problem, I think, is not mainly in the cholesterol and triglycerides. The problem, the patient has 30% ejection fraction and a basal crepitation. This is heart failure, the patient with heart failure. This is the most important thing. So usually we start with what relieves the patient. Relieve him from his heart failure, whether you use ACE, diuretics, whatever, to improve his condition. But the statin issue and the fibrate issue is something will come later on. Okay?
Any other comment? Yes, Dr. Gopal, our consultant cardiologist, International Hospital.
I completely agree with Professor von German. What he said that this patient should be given a dietary instructions and statin, because as per the NCP guidelines, the statin in type 2 with the level of cholesterol above 80, and with this clinical picture, definitely that's the fastest. And second, statin and fibrate can be given together. There is no contraindication as per that. But first you should go for diet and trial, and then you can go. With the 500, the chance of pancreatitis is not 20%.
Thank you very much. So the same patient, if you want to manage his osteoporosis, would you recommend to give calcium supplementation or vitamin D or both or other? Any one from the audience want to give comment in such case? Or we'll go to our speakers. Yes. Professor Badawi.
I think you go for both because if you give calcium without vitamin D, there will never be proper calcium homeostasis. Absorption of calcium and phosphorus is going to the bone. At the same time, you have vitamin D insufficiency. It's less, it's almost 19. So you need to give both. But in this situation, I usually give plain vitamin D and active vitamin D, and the calcium supplementation. Now, with the consensus in the last ACR that it should not exceed 500 milligrams daily as a supplement, calcium supplement, and the rest should be taken from natural sources, from the food itself. So I give both. calcium and vitamin D.
Professor Zaki, you have any consideration about these medications for the heart? Professor Zaki? The calcium and the vitamin D in presence of heart failure and ischemic heart disease, any consideration?
وعدد امبارح قال ان اي حاجه انا اقولها هيوافق عليها يعني you change your mind.
Okay, so no objection from cardiology point of view.
We'll have a debate about the calcium because the calcium
in the afternoon
supplementation in patients with cardiac disease is very important and we will have a debate about it.
We have an important session also, a debate after this session. Okay, so calcium supplementation plus vitamin D in this patient. Any comment, Professor Baz? Huh?
The calcium, what kind of calcium? Nasal or the oral?
Oral.
Oral. With this case?
Yes. And any other case?
No, because this patient has a lot of things. Dr. Adi says that he is going to heart failure.
Yes, but the calcium wanted to feel his heart failure.
No,
the vitamin D may improve his heart condition.
Yes, Professor Baz, you want to give comment?
I would give him vitamin D, especially if he lives in the northern part of the world. Germany, we have 6 months of winter sometimes. And because he's a high-risk patient, he had a T-score of minus 2.5. It's close to osteoporosis. It's boarding to
definitely.
It's a cut-off point here.
Yes, cut-off point.
I would avoid calcium, but just tell him eat cheese, hard cheese, green vegetables, all that, but no supplementation of calcium.
Yes, Professor Eckert, any comment from absorption, malabsorption?
I think I would agree with doing both. There's no reason to believe that there might be a problem with absorption or anything like that in this patient. And with the statin, I might add, I agree that you should give a statin, even if the urine enzyme is elevated. I don't know where the cutoff is, if it's 2 or 3 times the normal range. That really depends on, following the patient and watching them. But this patient is a patient with metabolic syndrome, most likely. And a lot of these patients with dyslipidemias have elevated urine enzymes. They have NASH, non-alcoholic steatohepatitis. NASH may be better when we give them a statin a lot of times. So I would agree for the other comments.
There is a question from the floor for Professor Baz, right?
The question I've had very modest doses of calcium. The recommendation 600 or 500, you said?
500.
500. And from Dr. Baz, we have said you are not recommending calcium.
We heard it in the morning. I'm not sure, but there are so many data that calcium could be bad for the heart, and he is a high-risk patient. I wouldn't dare it. I don't know, but I would recommend him to do it on a dietary regimen and vitamin D, but I wouldn't dare it, but I'm not the expert on calcium supplementation.
So, Professor, by the way, what type of salt? Calcium salt?
The best one is calcium carbonate, but it has a very bad absorption, so we usually give citrate or I think calcium citrate.
Thank you.
So let's move to the third question for the same patient. This patient is diabetic and his blood sugar RPS was 150, hemoglobin A1C was 6.8. So in patient with heart failure like this, for treatment of diabetes, would you recommend to continue the same oral tablet, to change to other oral tablet, or give GLP-1 agonist, or shift to insulin? Professor Baz.
Let's start with insulin. I'm sure the patient, he had an HbA1c of 6.8. He doesn't want to shift to insulin because, a lot of patients don't want to have this regimen, and it's not necessary. 6.8 is good control. GLP-1 agonist could be. It should be safe as to the heart. The studies say you could do it. And or other oral tab, I would shift to another oral tab to metformin. On the one hand to metformin, but on the other hand he has a cardiac failure and we have the problem of lactic acidosis, could be of lactic acidosis. But on the other hand he was on sulfonylureas, and the last studies we had, I think about meta-analysis of 35 studies show that sulfonylureas have a very bad effect as to the heart. And we will get new guidelines in Germany next year, and they want not to cancel, but sulfonylureas shouldn't be used anymore in patients who have heart problems. That's why I would shift to metformin, might be, or to the GLP-1, the DPP-4 inhibitors would be best.
Okay, thank you very much. Any other comment? Yes, again.
Why the DPP-4, why not the GLP? Professor, Dr.
Sorry,
why the DDP and not the GLP?
Oh, GLP-1 has to be administered with a shot, and might be he doesn't love it. But he's obese. You're right. He had a height, I think, he had a body mass index around 30, 32. You could do it too. But the DPP-4 inhibitors can be taken orally. So might be prefer this. But you could do it too. He's obese.
Okay, and the dose of metformin, anything new about that? Maximum is 1,000 milligrams twice a day. Anything, any change, or still it is 1,000 maximum twice a day? Or there is anything different?
The usual use is 1,000 twice a day, but in this case, if I give it, I would reduce it.
Because of the heart failure.
I would.
Thank you.
Any other comment? So it is very clear and very important for us, for any patient with diabetes, we have to be careful. Not only our target should be beyond the number, not only to control the blood sugar, we need to look for the safety as well, to look for complications. Because all of us knows many complications can happen to our diabetic patient. And our target while we are treating patients should be this. Our patient life should not be better because he is sweet. We have tried to take care of each and everything for our patient. So we make comfortable life